Good afternoon, everyone, and thank you for joining us today for our webinar on obesity care in communities of color. My name is Nicole Varner. I serve as Chief of Staff in the Office of Congressman Marc Veasey. Some of you may recognize me from other panels that I've worked with NMQF on. So thanks for being here today. As part of my work with Congressman Veasey, who sits on the Energy and Commerce Committee, we work on issues that affect everyone, including and especially minority and underserved communities. We work on issues such as voting rights, housing, gun violence prevention, health and fitness, and protecting and making more robust the Affordable Care Act. With a boss who works on the Energy and Commerce Committee, we know that healthcare is super important, and he serves a district that is was in 2016 had the highest rate of uninsured people in the country. So a lot of these conversations that we are having today are especially important for us. To shift away from myself now, I'm pleased to introduce you to our speakers today who have a wealth of experience regarding obesity care. Dr. Eric Griggs, an adjunct professor in the Department of Global Community Health and Behavioral Sciences at Tulane University School of Public Health and Tropical Medicine, and Michele Tedder, Senior Program Manager at the Black Women's Health Imperative, which is with a clinical background in mental health and as a nurse. Before we get started and jump into our conversation today, I have one housekeeping note for our attendees. And if you have any questions, please throw those into the Q&A box when you have a chance, but keep the conversation going and let us know where you're joining us from. So Dr. Griggs and Michele, tell us a little bit about your journey with obesity.
That is an interesting question. My journey with obesity. Wow. So I will say, my name is Dr. Eric Griggs. I actually live in New Orleans, been there for the last 30 years. Originally from North Carolina, went to Notre Dame by way of the Midwest and came down in Louisiana, New Orleans, and got stuck. What's interesting about the journey with obesity is, it's a term that has come to be vilified. There's a lot of different perceptions of what's obese. Part of what my journey, I am Assistant Vice President of Community Health Affairs at Access Health Louisiana, which means I do a lot of the public health things like public health communication. Where's he going with this? I'm on TV every day. I've been on TV for the last 10 years. And when COVID hit for the last 3 years, I've been on every day. I get, meaning I'm subject to the viewer's opinion, and I'm everybody's relative, meaning that people are fine with walking up to me and saying, "Oh, Dr. Griggs, oh, you look great. Oh, Dr. Griggs, you look really prosperous these days. Oh, baby, you look good, but don't lose too much because you're looking like you're too small." We all know the thing. It's the equivalent. Every pregnant mom does not want to be touched on her stomach. Every fat doctor, which is what they like to call us, which is a horrible term. Every doctor that's gaining weight doesn't like to be touched on his stomach either and say, "Oh, baby, thank you, but you need to lose weight." So the battle with obesity has caused, the struggle with obesity over the past, 26 years that I've been in this. There's a psychological component. Then there's the self-image components. There's the vilification of foods, and then there's a feeling of helplessness, and none of which are not treatable. And there are things that we can do, but we need to make this a more objective thing than a subjective thing, and we need to stop patting people on their stomach without permission.
Absolutely. And Michele, would you like to give us a little bit of your background in your journey with obesity?
Sure, absolutely. My name is Michele Tedder, and thank you for the opportunity to be part of this webinar. And my experience with obesity is both personal and professional. I am a person living with obesity and have struggled with it since I was a kid. And so I do know very much and can relate to what Dr. Griggs is talking about. You know, people making unwelcome comments about your size, you know, people judging you about it, those kind of things definitely are near and dear and personal to my lived experience. As a professional, I have become this obesity advocate and now subject matter expert. And how do you deal with and advocate for and support people living with the disease of obesity? And it's actually, I feel like it's part of my call and mission at this point to help people understand that this is not a disease of your personal failure. You know, you are not defined by your BMI, and that we do have various options, both behavioral and medication, as well as other things that you need in the toolbox to address obesity. I'm also a weight loss surgery patient. I had weight loss surgery back in 2017. So I just celebrated 5 years of keeping off 80 pounds. So I know the full spectrum of what it means to have access to those treatment options, as well as not just to gain control of your weight, but also to maintain the success. And I think that's another part that people don't talk about. And so as we have these conversations about why we need equitable access to all of the tools, I'm a living witness to tell you what having access to all of those tools can do for you. You know, prior to me losing the weight, I was struggling with type 2 diabetes. I had much higher blood pressure, joint issues, all kinds of things. And I can say that after my weight loss surgery, my type 2 went into remission. And I've been able to maintain my success because I have access to all of the tools that you need in the toolbox in order to change your life and change your lifestyle and to gain control of your health.
So first of all, Michele, thank you with us and congratulations on your 5th year anniversary, you said?
5 years. Mm-hmm.
That is fantastic and it's phenomenal. And you know, I myself lost like 50 pounds at one point in my life and have been able to keep it off for quite a while. So I know what an accomplishment that is. And I just want to make sure we give you your flowers.
I appreciate that. I appreciate that.
Of course, of course. And you know, the difficult part about, I think, talking about obesity are a lot of the misconceptions that people have. And so, Dr. Griggs, could you talk to us a little bit about these misperceptions and then why does, and give us a little bit of background on why science now is indicating that obesity is a chronic disease?
So first of all, I'll start with the last part first. The numbers are catching up. The numbers are there. Obesity is multifactorial. It's not just a societal thing. It's not just it's not a personal failing. And I think that is the big myth that's out there. Now, we talked about personal journeys. I'll never forget. I was lucky enough. I walked on and I played football in college, and I had a lot of former athlete friends on all levels, from college to professional. And for whatever reason, the further you go along in the athletic journey, you always think that it just takes 2 weeks and I'll be in shape. Until you hit med school, until you hit age 30 and 40, and then it gets more and more difficult. The average American gains 1 pound a year, which surprisingly, people, are you ready for this? That's only 3,500 calories. And it doesn't sound like much, but it's an extra 100 calories. If you want extra 100 calories a day, you eat an extra soda, an extra cold drink, an extra bag, little snack bag of chips, will add 1 pound a year. Per year, it equals up to 3,500 pounds. So the thing is, what happens is, especially when you take the approach from the former athlete, it'll only take me 2 weeks. You're gaining all your habits from your family and life, and then all of a sudden you stop with all of the excess activity, and your eating habits stay the same. How many of my friends do I know that are former professional football players, college football players, high school football players that have issues with things like sleep apnea? Because they keep the same eating habits. But there's a big misconception, first of all, You can't outrun a bad diet. I don't care how much you run, I don't care how much you exercise. If you don't have access, and if you do not take advantage of access to healthy foods, you will not lose weight. Exercise is great for cardiovascular health. Weight loss is a multifaceted approach, changing the relationship with food, and most importantly, changing the relationship you have with your own self-image and yourself. So thinking that it's a failing, it's not a personal failing. There are a lot of things that come into play when you talk about obesity. And then we talk about obesity as a chronic disease. I want people to understand when we say the term chronic disease, it's the same, it's the health literacy of it. When we say chronic disease, we mean like hypertension. We mean like diabetes. We mean like asthma. We mean like arthritis. Any of those chronic conditions that you've heard about before, instead of taking it in the subjective and the self-judging label of I'm obese, put it in the scientific category of the other chronic diseases, and all of the tools available and all those things that you have to do. Should you have a heart attack, should you have heart disease, they talk about lifestyle changes, and there's multiple comprehensive support mechanisms in order to help you be successful, to be healthy. It's the same thing with obesity, but the big thing is it has to start with what we're doing now, having these conversations, these uncomfortable conversations, and knowing that your body habitus is not a bad thing. You're in full control and you're beautiful no matter what.
Thank you. I think everybody needs to hear that sometimes, because, you know, the media makes it difficult for us to feel like our bodies are as good as they can, or are good. That's just difficult. So, and, you know, people gain weight for a multitude of reasons. Some folks have comorbidities. Some people have, you know, no education on what it is that you should be eating or doing with yourself, especially in our community. So going back to, I think, the comorbidities, could you talk a little bit about that with us?
Yeah, so let's talk about comorbidities. A lot of times, unless you're a college student or a second year med student or public health student or nursing student, you have no idea what comorbidity is. Morbidity means sickness. Comorbidities are the things that come along with what's being discussed. What comes with obesity? What's it associated with? Those supplemental things. That would be like your type 2 diabetes, the cardiovascular diseases. There are a number of cancers that are associated with it because there's an inflammatory state associated with eating more food, overstressing the GI system and the other systems of the body with too much energy. It's all about it's energy and energy storage. And then of course, there's also the fallout is the increased cost to the healthcare system. But the good thing is none of this is foreign to us. We do this with diseases all the time, but it's a matter of accepting it as a disease rather than a judgment. And I think that's something that we're having to deal with on both sides of the healthcare line, from the patients in the community to also on the healthcare provider side. We have to change our perspective on this and treat this successfully as a disease, chronic disease.
Right, right. And, you know, part of being able to treat it, I feel like, as a chronic disease is just having access, right? Access to information, access to healthy foods, because, you know, a lot of folks in our communities live in food deserts. And, you know, it's one of those things that unfortunately I feel like affects lower income and people of color more often than others. And Michele, I think you can talk to us a little bit about some of the other barriers and including that one in accessing obesity care.
Yes. Yeah, I agree with much of what Dr. Griggs just outlined for us. I think that, you know, weight bias from healthcare providers, I know in my own personal experience, even though I am a nurse, I am a health professional, you know, all of those things, but I can tell you that in my journey, before I finally figured out what was going to help me to lose the amount of weight that I did, a lot of the bias that I experienced was actually from other healthcare providers. And so, you know, what I mean by that is that oftentimes, I mean, you know, we're defined by our size as opposed to the symptoms that we're presenting with. And I think that oftentimes I've walked into, like, I can share a particular story that always stands out in my mind. I had a knee injury some years back, and this was before I had lost the weight, but I clearly had a knee injury. I was working out with a trainer, go figure. It was one of my many attempts at wanting to lose weight. And anyway, so I had a torn meniscus. And I kept saying to doctor after doctor, like, my knee is not functioning in the way that it should be. And I remember going to one of about 3 orthopedic doctors, and he said to me, well, lose 50 pounds and come back and see me in a month. And, we'll figure out, promise you. I never forgot it. I felt demoralized. I felt just like helpless, exasperated by, like, what am I going to do about this situation? And so it just so happened that another physician who I'd had a relationship with referred me to another orthopedic doctor who did not just see me as an overweight female, but was floored that that was my experience, and said, this should have been repaired 6 months ago. So, so I give that example of how it's really important for us as healthcare providers to really broaden the lens around how we are looking at patients and see everyone as an individual, not their size, not their BMI, because it really causes a lot of other issues that can actually be detrimental to our health when we look at things from one perspective. So that's one issue. And I think that a lot of times, because most of us who are trained, whether it's nursing school, whether it's medical school, whether it's PA school, we're not taught about obesity and how do you work with clients who are living with this as a disease, because first of all, it wasn't declared as a disease until 2015. So okay, there's that part that we're working through and trying to change that narrative and mindset. The other piece is that, like, your primary care physicians, most of them feel uncomfortable treating it because they're not trained in that specific area of medicine. And it does require a specific skill set in order to help clients to understand it's not their fault. I mean, research supports the fact that that your internal body fat is actually regulated just like your body temperature. So if you're dealing with that and you're somebody who's predisposed and living with this disease, you need healthcare providers who know that and can operate and figure out treatment plans that keep all of those things in mind. So, and we're not all created the same. And traditional diet industry does not support sustainable weight management. And that's what we're talking about, is to be able to figure out what are the tools you need in your toolbox, what are the treatment plans, comprehensive, that are going to help you as an individual live vibrantly with the disease of obesity.
Mm-hmm. That's all of that is so salient to us. And I think where we can dive a little bit deeper into the conversation is circling back to what I was talking about earlier, communities of color, Black and Latinos suffering from the disease at a higher rate than other folks in the American population. And so as we kind of think about that, and we are now talking more about equity and health equity and, how we address it, can you guys kind of talk to us a little bit about how comprehensive obesity care is important to achieve this health equity?
Yeah, so if I can first, what I always like to do is I like to level set. It's the terms. When we're dealing with the community, particularly our community, a lot of times we're less exposed to the current jargon or the whatever the hot acronyms are. I can talk. I have countless examples of when I go out in the community and we're talking about food deserts, and they're like, "Doc, this ain't no food desert. They got a corner store right over here. We got a grocery store right over here. You want some chicken? Like, what you want? Like, I mean, you can get you a plate. I mean, understanding and fully understand when dealing with the community, we have to acknowledge that it's a bidirectional arrow, right? You have the sender message receiver equation. And a lot of times we think because we know what the needs are of the community, that they have to listen to us and no one talks to them about what they want or what their perception is. It's a bi-directional arrow where we learn from the community as much as they learn from us. And what this speaks to is, Michele, this is, that doctor needed more of that type of education from the right people in the right place, so it never happens again. Once we teach them how the rules of engagement with those communities, we take the time and do our due diligence to understand what would be most effective, is when we'll start seeing the term. When you use the term food desert, we on this call and most on this panel know, I mean, on the panel and most on this call know that a food desert means that there's a lack of nutritional food options for a particular community, though there might be a lot of food that is calorie rich, it's nutrient poor. The sad thing is that in these same food deserts, those things are the ones that are perceived to be most affordable. Some of the solutions that we've tried, personally have tried, and we're still working hard. I work with the 100 Black Men of America. I work I'm the health and wellness ambassador for the state of Louisiana, the city of New Orleans, in a city where I love my people. And the way that we show our love to each other is we give them more food and more alcohol, which is not good in the conversation we're currently having. And trying to change that, something that's been happening for 3 years, it's a labor of love, but it's truly a marathon. And understanding that once we start with pulling in the community to be our troops and to teach them the words. That's why we have community health workers, but they don't have to have an official title. Just talk to people. You know, it's funny how, you know, our community spends all this money and time to send us to these schools to learn these big words and brag about how smart we are. But then the moment we go back and turn to them, we act like we're too good to use the regular words that they taught us. Teach them what they mean. My grandmother passed in 2014. She had a high school degree. There'll never be a day in time I can get a Nobel Prize where I'll be smarter than my grandmother. It's not going to happen. My point is, health equity starts with equitable conversations, even amongst ourselves, with our families, leveling the playing field, talking, having those hard and difficult conversations. Mama, just because you are 250 pounds and I'm 250, it doesn't mean that that's the healthiest thing for us. Let's do something what can we do? And that's part of the problem that goes along with obesity. And that's why it's a chronic disease, because there's a feeling of, I mean, we've all lost weight. I've gained 50 pounds. I've lost 40 pounds, gained 50, lost 20, gained 30. And then at a certain point, you feel helpless. So that means I need that type of support. With any other chronic disease, you could call, I need a referral. I need a therapist to help talk me through this as I change my behaviors. Can you teach me the science? Do you have something that can help with the science that's going on to help me with this, something other than, and I'm not disparaging my surgeon colleagues that fix everything with a knife, but something other than surgery, or even after surgery, do you have anything in place that can help me maintain the success?
Exactly. And, you know, I mean, there's hotlines for some chronic issues, right?
Right. Hello.
Get a hotline.
Hey, that's a great idea. I might think about that one. Yeah.
Yeah, Drake got a song, Hotline Bling. We can name it right here. We can name it right here, and it'll be popular. But having real conversations about real conversations, injecting the science so people can own it, like we're doing right now. We're trying.
Yeah.
Hotline Bling. I wonder if Drake will let us get away with that.
I don't know. We should call him up. Somebody got a connection. have that conversation.
We'll get Brandon Garrett to work on it. If anybody did you have anything that you wanted to add to that, this part of the discussion, Michele?
Yeah, you know, I agree. I agree that equitable, and I was on a webinar recently and we talked about compassionate conversations. You know, it was directed at healthcare providers being able to have compassionate conversations around the issue of obesity. But I think that us being able to have those conversations within community and helping people to, like I said, understand what this is and what it isn't. Because I mean, that has been a very, very important part of my own journey. And I will say that access to all of the tools, because I've used them all and continue to use them. You know, surgery was something, I was not making the type of progress that I needed to make without that. So I consider that to be the grace and the guardrail that I needed in order to help me to then institute the principles that we've been talking about in terms of lifestyle change programs, medication. I still take medication to help to maintain my success, but that's all part of the longitudinal, you know, and chronicity for the treatment of someone living with obesity, right? So I think that I'm such an advocate about everyone having access to all of those tools is because I know what it did for me. It cut my blood pressure medicine in half. Sleep apnea numbers went way down. Type 2 went into remission. So I think that really when we talk about equity and access, I think it's really important for us to have those conversations both at the ground level, at the micro level, but also at the macro level, meaning policymakers, and really trying to move the needle on the policies that put up barriers to people who are actually impacted the most by these illnesses, these chronic diseases, obesity, and the comorbidities that comes with that, right? So I think that it's important for us to be able to have those conversations on all levels, you know, and like Dr. Griggs said, really breaking it down within our communities so that people understand what we mean when we say food desert. It simply means that we don't have access to food as medicine, right? And so that those are the kinds of things, and to equip people with that information so that they too can be on the ground pushing policy conversation around what it's going to take to make our communities healthier.
Exactly. And you know, talking about our communities being healthier, the CDC has doubled the number of states that they've designated as suffering from severe obesity. So Dr. Griggs, as this prevalence rises, and we imagine it's mostly in our communities, right? How important is it to reverse this tide?
So it's it's imperative. We lived it the last 3 years. We've become more sedentary. I don't know about y'all, but I mean, this webinar is great, but wow, like there are days I can remember sitting down at 7, 8 in the morning and not getting up until 6 at night. Sitting has become the new smoking. Though exercise you can't outwork a bad diet. It is an essential component to our health, our cardiovascular health, but it also helps us burn calories. It helps for our mental health. It runs a gamut. The bottom line is, I think that roughly 40% of the American population is what's considered obese. And we can get into the whole conversation about BMI, with a BMI above 30, where childhood obesity is increasing. You know, it's one of those things where how long are we going to have this cognitive dissonance that this is a chronic problem? This is a problem of science. Again, it's not something so subjective. Of course, we know that if we improve we're able to reverse this. Personal outcomes, that goes without saying, but it's personal outcomes with support. If we properly do this, if everyone comes up with a magic wand and all of a sudden you're able to lose 50 pounds immediately, is the damage done all over those years that you've done over those years with the conversations I know I had some days in the mirror? Has that been repaired? No. It's a fully comprehensive approach to all of this. If we come from generations of, there's a lot of generational guilt. I don't know if you all have heard this in the conversations before, but the great grandmother or the grandmother said, I didn't know I was just loving on my baby. I didn't know I was doing something wrong.
Mm-hmm.
This is all that we had. So what we do is you take the paradigm and you flip it on its head. And rather than say, this is something negative, this is a survival mechanism. You say you have a food that, let's see what we can learn and how you can reverse it. In my own family, my grandmother, I talk about her all the time. She was diagnosed with diabetes when I was 11, hated needles. She was roughly about 230. She was 5'6". She was a cafeteria worker. She had all of us to start eating off a smaller plate. She drank water with every meal. She had the discipline to stop eating at a certain time. And then we started walking on Saturdays, but we started having conversations about health in our family. Like my grandfather was not, he wasn't happy about that. He wasn't eating no small plate because he wasn't no kid, is what he would say. But the point is that the power is in the hands of the community if we properly give the science and offer it and make it available across all communities. Because obesity is not just, and I want to be careful when I say this, I want to be very clear. Even though we're focusing on the African American and the Latin and the minority populations, obesity is not just a problem of those of our populations. It pans the globe, it crosses all demographics, and it's a conversation that needs to be handled collectively. Again, not even the higher resource communities know to use the tools, all of the tools that are available to them. Obesity, we're changing this conversation from a hopeless conversation to one of hope by calling it a chronic disease that we can deal with like we deal with everything else. That makes sense? And it just like Michele said earlier, it works back from the community up to the policy.
I thought I was gonna do it without me talking on mute this time. I didn't make it, but I'm trying. You know, I do want to cover one more question really quickly and then get over to the audience questions. We got a few folks who have inquiries, and y'all, just a reminder, you can put your questions in the chat box and I'd be happy to ask our panelists their thoughts. But we've talked about, you know, policy, and we know that Medicare covers bariatric surgery and some behavioral interventions, but it doesn't cover FDA approved anti-obesity medications, which is, you know, I think highly effective and less invasive than a whole bariatric surgery. And so what can the lawmakers be doing, or give us some perspective on what Medicare should be doing to cover the full continuum of care for chronic obesity?
So you want the quick answer?
Right.
Catch up. Catch up. You got the VA covering it, you got TRICARE covering it, you got the federal employee health benefit covering it. Catch up, because it's coming no matter what. Those treatments are effective without the dangers of bariatric surgery. I'm not vilifying bariatric surgery because it's a tool. It's a needed, I think it was the term guardrail. It's an effective guardrail, but there are so many things in the realms of medicine. You have internal medicine and you have surgery, right? You have a cardiologist, you have a cardiothoracic surgeon. From the medicine route, they call it the more conservative route, but it can be just as aggressive as need be without the actual cut. There's ways for all of these things to work together like they do with other chronic diseases. So all we're asking is that these AOMs get their just due. Michele?
So yeah, I do agree. I'm definitely a full spectrum girl. I feel that somebody who literally lives with the disease of obesity, I can tell you that I had all kind of tricks up my sleeve, right? I had a great PCP who was able to walk me through and help me to first off understand. So, right, there was knowledge, even though I'm a nurse, have been one for a really long time, I still had a lot of the guilt and the shame and thought it was my fault because I was doing the things. I had done the lifestyle change programs. I even started programs for people to lose weight at my church through our health ministry because I was the health minister at the time. Everybody else lost mounds of weight and I was still struggling. So I'm sharing that to say that I am a huge advocate that there be access to, yes, medications, access to surgery, access to lifestyle programs, because you need them all. You need them all. You know, it's like, so when you are doing all of those things, and that's the frustration when you're a person who lives with obesity, you're like, okay, well, A plus B is supposed to equal C. If I exercise more, if I change my diet, this should equal massive weight loss. For someone like myself living with the disease, that was not the case. So I'm simply saying that I think that, yes, we should have a continuum, right? It's a continuum of care, just like everything else. Like if you have a heart issue, we don't automatically jump to surgery. We absolutely don't. But I do want to level set and make sure that the audience understands that most people who end up needing to use the tool of surgery, that wasn't the first thing that they thought about. It literally took me about 3 or 4 years to be convinced that that was a tool that may be of help. And it was, no regrets whatsoever. But my point is that like Dr. Griggs says, and like I'm emphasizing, you need the whole continuum. So I think that Medicare absolutely needs to get on board, right? Because the other thing is that it doesn't make these evidence-based treatments available to the communities that are most vulnerable, that, have the comorbidities that come with obesity. And so they absolutely need to get on board. And so I think we have to be that voice, those advocates, and equipping the people that we serve to be advocates actually also to push this needle.
And that's exactly right. Losing weight is not an easy thing. It's counterintuitive. Like Dr. Griggs was saying, you think you eat less, you work out, you do this, you said the same thing, Michele, and people can't do it. In the chat, someone has asked, although we know BMI is an inaccurate way to determine health, many communities are familiar with that method. What additional methods would you suggest to use when discussing weight/health in communities with limited health literacy? This is a really good question from Juliana.
Mm-hmm. Well, I think more accurate measures of health, as research supports this, is looking at waist circumference, because we know that, like, if you carry more visceral fat, they call it, in your midsection, that's an indicator of you being at higher risk for things like cardiovascular issues, diabetes, etc.
Comorbidities.
Yes. Taking a look at high blood cholesterol, making sure that you know what your numbers are, where cholesterol, your triglycerides, meaning, the types of fats that are floating around in your blood. Also, your high blood pressure. All right, that's another better measure. And of course, high blood sugar. There's so many people who are pre-diabetic and don't even know, because they haven't had a blood test, or maybe nobody's screening for that when they do go to the doctor. So really getting these markers is a better indication for health. And I'll add that we have to remember, probably many people on this webinar probably know, that the BMI, it was developed in the 19th century by a European mathematician, right? And it was based on an entirely European population. So what the BMI does not do, and was never intended to do, is that it does not account for diverse populations. It does not account for body fat percentage, and it does not account for body fat distribution. Those are the measures of health. So we have to put it in its perspective, right? So BMI was developed for general populations, but we must remember that the general population did not look like us. So just say it. Just want to put it out there.
And I'm so very glad that you brought that up, because I think, as a young person and as a woman of color, we are shaped a little differently. Our distribution is a little different. But we will beat somebody like me, who, I know you can't see me, but somebody like me would be told that I'm overweight because of that distribution that a lot of women of color have. So I'm so glad that you were able to bring that up. Dr. Griggs, did you want to hop in on the BMI discussion?
Yeah, there's a lot of things. The BMI discussion, you're right. They didn't look like us. Again, I deal with a lot of former athletes. We have larger muscles and larger muscle distribution. There's just a lot. But the thing is, as a rough guide, if that's what we have to use, that's fine. But the more practical things are like your waist circumference, that dress you want to get into, or what I tell people, what the discussion that I have in the barbershops down here is, man, how much did you weigh in high school? How many times in our community have you heard, especially I've heard men say, oh no, I don't want to get too small now. That's too small. How is that not too small if you say that you are in the best shape of your life, you had no worries, and you feel great? That it's changing. We need to start having those conversations to change our perception of what healthy is, so we can we can work on that, what happy is when we look in the mirror. The first thing we do is we forgive ourselves, and we need to let our mindset and ideologies change as more of the science catches up. We need to put it more out there that these are the measures you should be looking at other than BMI, like on signs, so people can start to know their numbers. They can start to realize, instead of looking at the scale of the BMI, can I wear, you know what, I'm wearing my high school Letterman's jacket again.
Exactly.
And I feel great.
Exactly. And you know, we brown and black people love to say, well, don't get too skinny, don't lose your curve.
Yeah.
Right, don't lose your curves, like curves. And that's okay. I mean, I think there's room for self-acceptance, but we need to just look at our health markers. So, you know, if that blood pressure is not quite right, we need to work on that. You know, if the triglycerides are a little high, we need to work on that.
Exactly. And
I'm seeing in the chat, it said high school. Is that realistic though, after kids and such? Anything is realistic as a goal. And realizing that it's not, you come up with the health, you go to your healthcare provider and say, my goal is to get to my high school size. And then, but doc, I've had kids and life has happened. Okay, let's come up with a realistic goal based on these biomarkers that Michele just brought up. Let's talk about what your hemoglobin A1C is. What is your current blood pressure? Let's talk about, are you exercising 30 minutes a day? How much can you walk? Does that make sense?
Mm-hmm.
Exactly. And that also, there's another question in the chat asking about the role of hormones in weight. We've talked a lot about blood pressure. We've talked a lot about triglycerides. So, you know.
Yeah. So if you want to talk hormones, we can talk about HMGA, CoA reductase, PFK1. We can talk about ghrelin. We can talk about leptin. We can talk about estrogen being involved. We can talk about insulin being involved. We can talk about cortisol, insulin resistance. We can have a full biochemistry lecture. The bottom line is the hormones are definitely involved. The stress hormones are the ones that we're most in this country, in this world at this point for the last 3 years. We've been living in what's called stress soup. And stress soup. The two main stress hormones that we're concerned about are it's cortisol and epinephrine. Epinephrine raises our blood pressure. These are fight or flight hormones. They raise our blood pressure just in case we have to run or fight. And cortisol simplifies our decision making, but it also helps regulate and deregulate our metabolism. And chronic elevation of these, of cortisol especially, can lead to what's called insulin resistance, which can lead to weight gain. What am I saying? Your hormones can definitely be tied to your mental health. My name is Eric, and I'm a stress eater. I will eat in my sleep. I wake up with bags of potato chips and whole bags of food and whole plates of food beside the bed that I don't remember getting because I'm stressed and I'm not getting enough sleep. And recognizing that and recognizing those triggers and making it more challenging for me to get to the refrigerator without hurting myself, and then talking to someone so I can stop this, and doing those things to decrease the stress level, so I won't have that stress before I go to bed. So hormones are definitely involved, but as you can see, I'm hoping I'm painting a picture. All of these things are tied together, which is why it takes a multifaceted approach. It's not just a fitness trainer that can help you with it. You can go to your doctor's office and you can get things to help you. You don't do the same thing with your blood pressure. Your blood pressure is tied to hormones. You take pills. If you have to have surgery, then that's something bad's happened. Why wait and use something that's a guardrail when you can do all these things leading up to it, and then use these things again if you get to it? Does that make sense? I mean, support afterwards is much as important as the support moving forward. That's my hormone answer. How about that? That's my hormone.
I think we probably need to come back and have another panel just on hormones and weight gain.
I think especially for women, especially as you start to approach menopause, there's, you know, a lot of impact and a lot of things going on that are out of your control, and I can tell you, somebody who is, you know, been there, done that, it does have a significant impact. But I think what's key is equipping people with the tools and the information in order to, one, give yourself the grace to know that, like, your body does kind of like operate in this like really high level biological way that sometimes it's not, you are working against it. But, you know, I will say that being able to get into like the Black Women's Health Imperative has a lifestyle change program called Change Your Lifestyle, Change Your Life program that addresses those kinds of things. And it, you know, it's culturally tailored, and it gives women, Black women, the tools necessary to deal with how do I deal with stress? How do I deal with when, you know, I'm going through menopause and I'm doing all the things and my weight's not coming off, all of those kinds of things. It's important to have the knowledge, and having a village and programs like that can help you as the individual know how to approach that within your own journey. So it is comprehensive, you know, dealing with obesity is comprehensive. So if you don't walk away with anything else, walk away with that. Like, it is a multifaceted, comprehensive issue.
And to that real quick, just to add to that, Michele, is, you know, everyone's talking about the BMI. Go to your healthcare provider and ask about your basal metabolic rate. What is your baseline metabolism? How do you metabolize the things that, how often you eat, how much you eat? It's individual to everyone. It's just not a one size fits all approach. Let's talk about the basal metabolic rate. Find out how your metabolism is affected. You know, if you put yourself in a state of starvation, your body goes into starvation mode and starts saving and storing. Oh, you know what? She doesn't know what she's doing. We're gonna take this and put this up for later. That's good. We're gonna put that there because that's what happens if you lose too much weight. Your body thinks something's wrong. Whoa, what did she do? Hold on, look, let's just store everything in case she does this again, and let's start triggering her to go back to the potato chip aisle where Eric is getting all the potato chips. So he doesn't get sick. Real practical conversations with each other and with our healthcare providers to build your team so you can win.
Well, listen, I love a good bag of Zapp's potato chips.
Ooh, won't he do it?
Won't he do it? I went to school in New Orleans. I developed my love there. But you know, we do realize that all things in moderation, right? I think we talk a lot about keeping ourselves from having things and reorienting the way that we think about eating. But, you know, I've always thought it's okay to have a piece of cake every now and again, just every now and again.
The thing is, every now and again, and then the thing is, we confuse, Michele, tell me if this has been your experience, we confuse the messaging, right? We want people to work out, and then we tell them in order to lose weight, you have to eat less. In order to work more, you have to eat more.
Eat, yes, that part, that part.
I mean, so now you're mad at yourself. You feel good because I just exercised on the Peloton for 30 minutes, and now I'm hungry. Oh man, I can't eat. And then you eat, you don't eat enough, and then you get hungry again, and the next thing you know, you're making a plate of red beans in the middle of the night in your sleep. You do the whole thing. This is why it takes a comprehensive approach to this, to talk about the science and how it really works. And that fitness trainer, I don't know about y'all, but you know, I think I thought about trying it until I saw this dude that looked like I did in college. I'm like, I'm not going to him. You're killing me. I'm 50 years old. I can't do that. Being realistic with yourself and accepting who you are. Am I right?
You know what? I'm gonna tell you what, Dr. Griggs, I'm very selective about my trainers. I've had the same one for about 4 years now, and he's not that dude. He's a guy that look like I'm not gonna jump up, you know, don't have me jumping on boxes because I'm too old. I'm not doing it. Okay. It's like, you need to design a plan for the old lady in the room. Not like I'm not doing all that. So that's, you know, that's right. We're being funny, but the issue is you do need people who can respect where you are and meet you where you are, right? And I also tell folks that I support and help around this issue. Listen, there's not bad foods and good foods. You have to choose foods and eat, enjoy your food. Because listen, I'm a foodie and I'm going to be one until I die. self-proclaimed. I'm not even going to lie to you. I love a good bag of Lay's potato chips. Here in
Oh,
Pittsburgh, there's a
oh.
company called Snyder's. Love those too. So every now and again, I have some, but I know that I can't do that every day, right? And I know that there has to be a balance. That's what the lifestyle change part is about. That's what the mental part is about, is really then doing the work around what is your relationship with food? How do you want to interact with it that is going to support your overall health and well-being? And that's where we have the control. That's where we have the ability to decide and work with professionals like trainers and nutritionists and attend lifestyle programs and all of those things. That's where we have the control, is to get those tools so that we can make the right choices. But good food, bad food, no. I enjoy all food, anything. And at Thanksgiving, I had my sweet potato pie.
Yes.
I had all the things that I wanted to try. I just did it in moderation. So
the beans, greens, potatoes, tomatoes,
That's right. All of it. That's right.
I need the recipe for these red beans that make you get up in the middle of the night and not. That's what I need.
Right. And I think, Dr. Griggs, I think I've seen you in the chip aisle. I don't know, but
you name a chip aisle, it's me. Just wave, keep it moving.
Well, we're coming to the end of our time, and I have very much enjoyed this conversation, and I've learned some new things myself, and I've been doing health policy for like 8 years, so this is great. In the few minutes that we have left, do you folks want to give your final closing thoughts?
And I promise I'll be brief. I saw a comment in the chat. This is the holidays. Tomorrow's my birthday, and I am going to have cake. I'm going to have cake and chips. Thank you very much. Yes. But there was a thing. It is the holidays, and there was an ask for mindful eating strategies. Let's talk about mindful eating is. What it means is what my grandmother did, right? I want you to think about. I want you to enjoy the food. Food is here. We love food. We're all foodies. Some of us like some food more than others, like me and chips. But the point is, mindful eating means taking the time to think. And at the center of all this, slow down. It's the holidays. I want you to give yourself grace to enjoy your holidays. Forgive yourself if you're on that fight. And what mindful eating is, the biggest strategy is you take one bite, you chew, and enjoy. Put your fork down, have your phone down, and enjoy the conversation and the people you're around. Think about the taste. Enjoy the taste of every bite. What happens is it slows down the amount of food that you'll eat, believe it or not. You're drinking your water, you'll find yourself eating less food and enjoying more. And the less you eat at one time means the more that you can eat over time. And the answer lies with you.
Absolutely.
Michele?
I would say I have learned to approach myself from a place of love, and meaning that the choices that I make around food, the choices that I make around who's in my inner circle, the choices I make around choosing to exercise are grounded in love and care for myself. And I often ask myself, is this contributing, right? Is it adding to the best person and me living to my highest self, or is it not? So if I have that conversation, I make choices based on that. So, on the days that I may not want to exercise, I'm like, well, but that's an act of self-love, right? Being able to take a walk and enjoy the nature and that kind of thing. So it moves it from, I got to do this because I need to lose weight. No, it's like, this is another way that I'm showing love and self-compassion to myself. And so I think that, if you can think about that, your food choices, your exercise choices, whatever choices that you're making, if you can take it from a standpoint of you're choosing to love yourself at the highest level, then I think that you eventually learn to live that way and have a lifestyle that's representative of you being your best self.
And that you're beautiful no matter what. And if they don't like it, tell them not to look.
There it is. There it is.
There it
is. There it is.
Well, folks, I know that I think we got to everybody's questions, but if we missed anyone, I do apologize. We've come to the end of our time. If you guys want to have this conversation again, y'all just give me a call. I'll be happy to come back. Thank you so much for your time, Dr. Griggs. Michele, thank you for joining us. NMQF, thank you for having me and allowing me to chat with you all today. And with that, I hope you guys enjoy your weekend. Happy holidays. And I hope to see you again soon.
Thank you.
Thank you.